Our first session is called Cognition and Health-Related Quality of Life. And our speaker is Jeff Wefel. So Dr. Wefel is Associate Professor and Chief of the Section of Neuropsychology with a joint appointment in Neuro-Oncology as well as Radiation Oncology at University of Texas MD Anderson Cancer Center. He obtained his PhD in clinical neuropsychology from the University of Houston after completed a residency at University of Chicago and subsequently his fellowship in the Department of Neuro-Oncology at MD Anderson. Dr. Wefel's research seeks to characterize the prevalence, pattern, course, risks, and biological and neural substrates for the development of cognitive dysfunction associated with cancer and cancer therapies. And ultimately, the goal is to lead to the identification and testing of interventions to prevent and minimize cognitive dysfunction. He is a cognitive studies chair in numerous cooperative groups, industry-sponsored research programs, and investigator-initiated clinical trials.
And thank you for inviting me to this symposium. This is really a wonderful opportunity for all of us to get together during these unusual times. And congratulations to UCSF, Dr. Jumper, Taylor, and Ware Jamora for organizing what is going to be really enlightening and invigorating. And as they were sharing earlier today, over 450 people have registered for this. So this is really, really exciting. And I appreciate the opportunity to participate here. The goal that I have is really just to present an overview of cognitive changes in patients with brain tumors, as well as the health-related quality of life issues that they face, and then really to open this up to the true experts that will be presenting to you the rest of the day. The goals that I have really are to set the stage for everyone else, to define the scope of the problem, to discuss an overview of contributors to and impacts of cognitive dysfunction on patients, to talk about strategies of maximizing cognitive function and health-related quality of life. So I think the first place to start is with some epidemiology. The prevalence or incidence relative to other cancers of brain tumors varies by age, and in children, it's one of the more common cancers that children can experience, though if you note here, it's also still very rare, only 5.74 cases per 100,000 individuals. And the frequency or the relative incidence of brain tumors decreases compared to other cancers as we age. However, the actual incidence of brain cancers is far greater in individuals over 40. Most brain tumors are non-malignant. However, we're going to spend most of this time, probably, at least I will, reviewing the impacts of malignant gliomas. And the most common malignant glioma is glioblastoma, and the incidence is higher in males and individuals who are Caucasian. For adults, this usually results in approximately 20 years of potential life lost, and in kids, this is even greater, about 80 years of potential life lost. In the United States, over 18,000 people will die from malignant cancers in 2020 and this year. And of course, brain metastases are far more prevalent, occurring in approximately 15 to 17% of individuals with cancer, resulting in 70 to 170,000 new diagnoses per year. Now, moving on to brain tumor pathology, that kind of very simplified categorization of brain tumors is that we have high-grade gliomas, lower-grade gliomas. There's also primary central nervous system lymphoma, which I'm not going to be discussing. And then, of course, we have brain metastases. This has historically been defined on the basis of histopathology. I have a few slides showing different features on histopathology. However, this is, as I said, quite simplified. And in fact, there are many different diagnoses for brain tumors. And more recently, there has been a surge of and an integration of molecular characterization of these tumors. So it's no longer defined based on histopathology alone. In fact, they're more predominantly defined on molecular features of the tumor, with the most common genetic molecular alteration being that drives diagnostics being the IDH gene. This paper recently came out by Ken Aldape and colleagues talking about challenges to curing primary brain tumors. And what they do is they talk about across different stages of tumor, there are focuses on different aspects of research. So in this kind of malignant phase, there's a lot of preclinical research that's going on. Now here they propose that the key focus area of research at the time of a cure would be late effects. And I guess one of the questions that I would challenge the audience to think about is it necessary to wait for a cure before we start facing and managing and dealing with and researching survivorship issues and late effects? And I think in terms of what patients and caregivers want, they say that a priority for them is to focus on this right now. The Jumpstarting Brain Tumor Drug Development Coalition conducted a survey of patients and caregivers, and they asked this question: in addition to allowing a person to live longer, what would you most like to see future brain tumor treatments do? And one of the top responses that came from patients and their caregivers, of course, is retain brain function, in addition to maintaining physical abilities and reducing pain, including headaches. So I think we have a very clear agenda from our patients and their caregivers that not only do we want to search for cures, but now is the time to also look for ways to help us manage and maximize survivorship. I would say parallel with this, we've seen some encouraging changes in brain tumor patient survival time that leads us to also wish to focus more on survivorship. So we know now that we can characterize through many of these molecular features patients who are going to have potentially better survival times, better outcomes in terms of survival time. And that's true for the gliomas as well as for patients with brain metastasis. Moreover, there are some treatments that appear to provide distinct benefit to certain subgroups of brain tumor patients. And even in our phase 3 randomized controlled trials, we are experiencing small, although meaningful gains from some new therapeutics in broad populations of glioblastoma patients. So with this in mind, I conceived of survivorship and some of the components of our patient care along a couple of different dimensions, and I use this picture to try to communicate this. I think we can think about the impact of these diseases and their treatment on the patients at a couple of different levels at least. Maybe the broadest level is health-related quality of life, and of course this can be influenced not only by the disease and treatment, but by other factors in the patient's life that drive their satisfaction with how things are going for them at the moment. Then more proximal to the patient may be assaying symptoms, things like headache and fatigue, some of which may definitely be directly related to the disease and treatment, but others may be, again, factors driven by other situations, such as depression, for example. Both of these are optimally measured by questionnaires, or what in clinical trial parlance is called a patient-reported outcome. What I believe is probably most proximal to the disease and the direct treatment effects on the brain and CNS is measures of cognitive function and brain function, things like our memory ability, our language ability. And these, of course, are maximally and optimally measured by cognitive tests. And in clinical trial parlance, these are called performance outcomes. Terry Armstrong and colleagues surveyed over 600 brain tumor patients with the MD Anderson symptom inventory with the brain tumor module. And they identified that 3/4 of brain tumor patients are presenting with 3 or more symptoms. The most highly rated symptoms at the moderate to severe level are fatigue and sleep disturbance, cognitive changes, and mood disturbance. And they found that these symptoms were functionally limiting in terms of your ability to maintain your usual work activities, walking, activities of daily living in 1/4 of patients. We also know that neurobehavioral changes are not infrequent, and often for caregivers are the most difficult things to manage. And in our brain tumor population, unfortunately, a relative minority of people return to work, and when they do so, they generally do so with some alterations in their work milieu, such as reduced hours, more limitations, needing for adaptations or increased time off, even if it's just for appointments that they're coming to the medical centers for. We also know that there are a number of comorbidities that patients face. The Glioma Outcomes Project sought to characterize the incidence of depression in brain tumor patients, and they asked patients via self-report surveys whether or not they're experiencing depressive symptomatology. And as you can see here, patients on the entire survey endorsed depressive symptoms. 93% of patients were endorsing some depressive symptoms. And just using the 3 questions related very directly to the most cardinal symptoms of depression, 73% of patients were endorsing symptoms of depression. However, when physicians were queried about whether or not those patients seemed to be depressed, they identified depression in just 15% of patients. And this clearly represents, I think, a communication gap between patients and caregivers, or patients and care providers. And I think when I talk with patients, I relate to them that we're not mind readers. It helps if you communicate these things to us. And when we think of this as ourselves as colleagues, we recognize that we need to create some space in our appointments with patients to also ask about how they're doing, because there's many excellent interventions available for distress, including counseling, support groups, behavioral activation plans, as well as medications. And Florine Boole has recently published another very interesting perspective on this, looking at healthcare utilization and productivity loss in glioma patients and family caregivers who are on average 3 years after their diagnosis. And they of course found that there was a significant increased costs in healthcare utilization for patients compared to caregivers, and there was quite a bit of lost productivity, of course. But one of the interesting things I think about this is she was able to identify a number of potentially modifiable factors that would contribute to this. And most of these are behavioral symptoms that may benefit from psychosocial care. So I think it's really worth investigating this further and identifying if some of these interventions could reduce some of these costs that patients and their families experience. So this graphic is meant to kind of list out a variety of factors that impact upon the presentation of cognitive dysfunction, and then how cognitive dysfunction impacts patients' life in a variety of different ways. And so I want to kind of briefly go over each, and know that the speakers after me are really going to take deep dives into these subject matters. So in terms of tumor location, we know that patients present oftentimes to their ERs with physical symptoms, often with headache, but we also have seen that many of these patients are also presenting with cognitive disorders, things like memory loss or language disturbances, as well as seizures and personality changes. And if we look at the epidemiology of malignant brain tumors, they occur most frequently in the frontal and temporal lobes. And it's not too surprising that when we look across high-grade glioma, meningioma, and brain met populations, that the patterns of cognitive dysfunction, in fact, mimic that in terms of what we understand about our brain behavior relationships, and that we most frequently see patients presenting with impairments in learning and memory processes and executive function. However, we can see that there are a broader non-focal, if you will, pattern of cognitive deficits in this population. And why might that be? Well, we know that tumors occur in a lot of different areas radiographically, but we also know that this is not a focal disease, that in fact there's diffuse pathology located throughout the brain, and hence a surgical cure for many of these infiltrative gliomas is unlikely, and it requires these adjuvant therapies that we all know patients are presented with. This has also been demonstrated through EEG and MEG studies, as well as fMRI studies, in which patients with these seemingly radiographically focal diseases experience widespread disruption and loss of functional connectivity near the tumor, but additionally in contralateral and diffusely throughout the brain. So we undertook a project with some of our neurosurgeons here at MD Anderson, including Jeff Weinberg, to examine the impacts of glioma in the temporal lobes, in the both right and left temporal lobe. And when we did this, we had approximately 100 patients who were referred to us in the early 2000s for preoperative neuropsychological evaluations, and we divided them into left and right temporal lobe groups. They were fairly similar on all demographic and clinical characteristics. And then we segmented the temporal lobes into an anterior portion, a posterior portion, a medial portion, or a multi-lobe involvement. When we looked at our cognitive test results, we found that 3/4 of patients were impaired on one or more tests. And this incidence of impairment was the same for right and left temporal lobe patients, but the pattern was somewhat different. Both right and left temporal lobe patients demonstrated high rates of impairment in learning and memory processes and executive function. And maybe this is somewhat surprising in that this was a verbal list learning task. So even patients with right temporal lobe lesions were showing impairments on this particular measure. But the left temporal lobe patients also had evidence of higher rates of impairment in things like language abilities, as well as auditory attention. Then when we looked at that temporal lobe segmentation, what we observed was if you had anterior posterior temporal lobe lesions, you tend to have these patterns of reduced learning efficiency and to a lesser extent a memory retrieval deficit. But when you had medial or multi-zone involvement, then there appeared to be a marked reduction of memory consolidation processes, or what we consider more classically as an amnestic memory disorder. So again, we can see here that tumor location does impact the cognitive phenotype that we see in these patients. We were also interested in how these new molecular diagnostics may relate to cognitive function and how they may relate to concepts of brain reserve. We have long been interested in this concept of lesion momentum, a faster growing tumor producing more cognitive deficits and maybe preventing the brain from reorganizing and adapting, as well as a slower growing tumor. And now we had a molecular genetic surrogate of growth kinetics, specifically the IDH gene mutation. So we had the opportunity to study a variety of patients who were presenting to us preoperatively for cognitive testing and whose IDH status was characterized by Dan Cahill and Ganesh Rao. And what we found was that patients who were IDH wild type had far greater cognitive deficits than those patients who had IDH mutant tumors. And we hypothesized that this was due to the fact that the growth kinetics, the faster growth of the wild type tumors, was leading to prevention of compensatory neuroplasticity and brain reorganization. And in fact, in this population of patients, the tumor size was a little bit larger in the mutant patients compared to the wild type patients. And the association, the correlation between tumor size and cognition was non-existent in the mutant patients, but was highly significant in the wild type patients, again, suggesting that the growth of the tumor was impacting cognition in the wild types, but not in the mutant patients. We then sought to examine the brain effects of this to confirm our hypothesis about functional reorganization, and we examined the structural connectomes of these patients. And what you see at the top is our voxel-based morphometry workflow, in which we looked at gray matter regions and then ran graph analyses and connectivity analyses. And what we identified was that the wild type patients had fewer connections in this ball and stick diagram. I'm not sure you can appreciate it in your view. And they also had fewer hub regions. And additionally, they demonstrated decreased efficiency in terms of brain connectivity metrics. So again, this was supportive of our hypothesis that the wild type tumors growing quicker prevented the brain from adapting to that new lesion and led to greater cognitive deficits. What about the impact of surgery on our patients? So we know surgeons are attempting to get a gross total resection, and their goals are to remove as much of the tumor as safely as possible. And in this scenario, we've asked the question, could preoperative neuropsychological evaluations help predict postoperative morbidities? And so we had the opportunity to take a look at our database, in which we had over 140 subjects who had pre and post neuropsychological evaluation before and after surgery. And what we identified here, and I just want to kind of draw your attention to this, is that in fact, preoperative neuropsychological evaluations were able to contribute in a multivariate model to the prognostication of postoperative outcome. And where I'd like to see this go is that we generate something like a risk prediction calculator, that these variables could be entered into a model, and we could inform our surgical colleagues about the potential risks of postoperative morbidities given their preoperative neuropsychological state. This has also led to increased incidence in our particular institute, and many others have been doing this for quite some time, in incorporating cognitive testing into the OR, into interoperative cognitive monitoring with direct electrocortical stimulation. And here, Dr. Kyle Knoll has been spending quite a bit of time in our OR using NeuroMapper to help shape how we could potentially mitigate surgical risk and help our surgical colleagues in their goals as well. So what about our own genetic background and the impact that might have in modulating some of the exposures that patients have in terms of radiation and chemotherapy? So we know that the goal of these therapies are to kill tumor cells and control tumor growth, but their risks are off-target toxicities hitting normal tissues, or on-target but off-tumor normal tissue toxicities. So perhaps trying to attack a particular pathway, but that pathway is also present in normal tissues. And we know that from a large recent phase 3 randomized controlled trial in glioblastoma patients, that the time that the patients experience rapid worsening of their cognitive function, even in that progression-free period, indicating perhaps some adverse effects of subclinical tumor growth, but also potentially some treatment toxicities. And there have been a number of strategies to try to risk reduce the exposure of these treatments to normal brain. In the radiation space, this includes things like intensity modulated radiation therapy or proton radiation therapy, in which the radiation dose drops off very quickly, preventing exposure to other healthy normal brain. And in the brain met population, using things like radiosurgery or hippocampal avoidant whole brain radiation therapy. We've also tried to reduce risk by incorporating cognitive outcomes in trials so that we can identify the most efficacious and least toxic therapy that we can then bring into the clinic and offer to our patients, and through the use of other molecularly targeted therapies. We've also studied neuroprotective strategies like the use of memantine during radiation therapy to try to prophylax the brain against the adverse effects of radiation. And there's great interest in regenerative medicine, metformin, ramipril, and exercise, as well as other approaches, some of which will be touched on today. So the pathogenesis of radiation damage is well described here by Macaulay and colleagues. And what I want you to take away from this is that many of these processes seem to be arising very early, within hours, if not days and weeks of initiating radiation therapy. And these neurodegenerative processes include things like vascular endothelial damage, inflammation and microglial dysregulation, oligodendrocyte injury, neuronal damage and altered neurogenesis, epigenetic aberrations, and a number of other abnormalities and processes that you'll hear well described by Dr. Monnier and Dietrich later this afternoon. There's also a number of radiation treatment factors that contribute to the likelihood of developing adverse cognitive outcomes upon exposure to radiation therapy, including the dose and location of the radiation exposure. And we've taken this forward into some clinical trials to look at whether or not we can modify therapies and enhance cognitive function. And some examples of this include trials in which we've demonstrated that SRS alone for the treatment of 1 to 3 brain metastases resulted in less cognitive decline than SRS plus whole brain radiation therapy, which has also been replicated in the larger Alliance trial led by Dr. Paul Brown. Similarly, for those patients who need whole brain radiation therapy, we look to see whether or not prophylaxing with memantine versus placebo would result in preservation of cognitive function, and that's what we found, that memantine delayed time to cognitive decline, presenting opportunities to mitigate against these toxicities. And we also identified that the ApoE4 gene was a risk factor for worse cognitive outcomes, again, helping us to understand mechanism and risk factors for patients, and hopefully guiding future trial enrollment as well as outcome prognostication. Then we've wedded some of these approaches where we've looked to see whether or not varying the delivery of whole brain radiation therapy to traditional whole brain or hippocampal avoidant whole brain would alter outcome. And again, we found that hippocampal avoidance prolonged time to neurocognitive function failure with no adverse effect on PFS or OS. As we think about how we maximize cognitive function and quality of life, I put this somewhat busy slide up, and these are the things that I'm considering in the context of Gordon Paul's ultimate clinical question of what treatment by whom is most effective for this particular individual with that specific problem under which set of circumstances, and how does that change come about. And so I think we always try to enroll our patients to clinical trials to maximize their outcomes. We think about whether cognitive training, physical activity, compensatory strategies, or a variety of psychotherapy or lifestyle interventions may improve their outcomes. And on the research side, I think it's important to be thinking about preclinical translational research and how we can identify mechanisms and potential therapeutics that we can bring forward into brain health clinical trials. Things like stem cell therapies, pharmacotherapies, and maybe even neurostimulation. And of course, critical to this is paying attention to the caregivers and the support team that patients have. And UCSF has absolutely pioneered a program in this area that we're going to hear much more about. So I think there's many translational science opportunities. This is one example coming out of Don Mabbitt's group in Canada. Ubiquitous published on the use of metformin to promote recovery of neural precursor cells. And they conducted parallel rodent human studies, and they demonstrated that metformin rescued neural precursor cells in the dentate gyrus and improved cognitive function in rodents. And interestingly, this was true for female rodents, but not males. And then they piloted a phase 2 randomized double-blind placebo-controlled crossover trial in survivors of pediatric cancers, which demonstrated that this was a safe medicine for them. And there was some early efficacy signals that have encouraged them to consider pursuing this further into a phase 3 space. We at MD Anderson have been considering regenerative medicine approaches. So with some of our colleagues here, we have developed a chemoradiation model within mice that generate cognitive deficits. And we've demonstrated that we can rescue those cognitive deficits with mesenchymal stem cells. Here's data from a novel object recognition memory paradigm in which we can see that the intranasal delivery of MSCs, but not the IV delivery of MSCs, rescued cognition. Similarly, it was able to restore morphological features of mitochondria as well as synaptosomal function of mitochondria, indicating that this may work through increasing bioenergetics within the brain. So with that, I want to stop and give time for the rest of the speakers. And again, thank you all for participating in this.
Outstanding talk. That was really, really impressive. You know, you raised so many important points. You know, in the next couple of minutes, I just want to maybe focus on 2 questions that came up that seem to be across multiple respondents. So if you're talking about cognitive outcomes and health-related quality of life, how do these separate, distinct measures, how do they overlap? Um, can you talk a bit more about that? What is the interplay between health-related quality of life outcomes and cognitive outcomes?
Absolutely, yeah. As I think I tried to capture with that graphic of the individual staring off into the sunset, quality of life is a very broad concept. It involves many, many different factors that impact upon our life and the satisfaction with the life that we're living. Cognition is one component that drives our satisfaction with our quality of life, but there's many other components that impact our feeling of well-being. These are our physical symptoms, right? Our motor disabilities, for example, or abilities, our relationship status, our financial situation. And brain tumor patients are experiencing a myriad of challenges to their quality of life, including impacts on finances, including symptoms like fatigue, pain, hair loss, disfigurement, beyond just cognitive function. So they're clearly interrelated, but health-related quality of life is not just cognitive function. And cognitive function can be distinct from quality of life. Some individuals have learned to cope and compensate with many of the changes and report really excellent quality of life. They are reconceiving of a new normal for themselves, even in the face of symptoms and deficits. So I think we focus on both of them, but there could be different pathways to focus on each.